So my name is Teresa Blackman. I am the Pre-Health Professions Advisor at UTC, and I want to welcome you guys to our very first inaugural event for the Mocs Move Forward, a discussion and application of diversity in healthcare series. We're really excited to have everyone. This is our first of 6, and we're going to be exploring the history of the African American experience in regards to healthcare. And I'm joined by Shawani Howard-Baptiste, who has been a huge help in getting this series off the ground. So I will let her introduce herself and then introduce our speakers.
Wonderful. Well, welcome everyone to our first inaugural series, and hopefully this is an opportunity for all of us to share and learn from one another. As Teresa said, my name is Dr. Shawani Howard-Baptiste. I'm an associate professor here at UTC in the Department of Health and Human Performance. So I teach at the graduate and undergraduate level, and I also serve as the interim program director for the Masters in Public Health. So I have the pleasure this evening of introducing our 2 guest speakers for our panel. The first guest speaker is Dr. Julia Comiskey, who is an assistant professor here at UTC in African history. She has a master's degree in public health from Columbia University and a PhD in history of medicine from Johns Hopkins University. Her research focuses on the history of international public health and medical research with attention to the ways that knowledge about disease and health is produced and disseminated. She is currently finishing a book on the history of virus research in 21st century Uganda and starting a project on the history of medical advertising in East Africa. So let's welcome Dr. Comiskey. Our second guest panelist this evening is Dr. Mark A. Johnson. He earned a PhD in history in 2016 from the University of Alabama. Previously, he earned an MA from the University of Maryland and a BA from Purdue University. Before joining the UTC faculty, he worked as a visiting lecturer at Georgia State University. He specializes in the history of the United States and specifically the U.S. South with attention to race, politics, and foodways. In 2017, he published a book with the History Press on the subject of barbecue. He previously published articles in Southern Cultures and Louisiana History on the subject of Black performance and politics in the Jim Crow era. In his next book titled Rough Tactics, Black Performance and Political Spectacles, 1877 to 1932, will come out next year with the University Press of Mississippi. So let's welcome both of our panelists at this time. And we just want to be mindful with the topic that we are learning and sharing about. Everyone is coming from a lot of schooling and educational expertise and different experiences. And so this is an opportunity for all of us to really share and connect with one another, understanding that each of us has our own lens and different experience that we look and see the world. So I will turn it over now to Dr. Johnson and Dr. Comiskey.
Thank you. Thank you for having us. I'm thankful to have the opportunity to talk this evening about this important topic. In this brief introduction to race and racism in American medicine, I want to focus on how the construction of racial difference and the historical treatment of Black people has contributed to not only lingering distrust of the medical profession, but also different treatments and outcomes. I want to discuss some of the earliest explanations for and about racial difference, because surprisingly, some 500-year-old ideas still have influence on medical practice today. Then I want to explain how treatment of Black people during slavery, not only by doctors and medical professionals, but by their masters and other white people, and treatment of Black people in the field of public health has led to some mistrust and some misunderstandings. So in the first moments of contact between Africans and Europeans, Europeans started to construct ideas about racial difference. And some of their ideas and theories have implications for medicine today, more than 500 years later. So although race does not have any biological basis, Europeans had many explanations for physical difference rooted in biology that ultimately shaped the earliest theories about racial difference. So upon encountering sub-Saharan Africans for the first time, European travelers obviously noted stark contrast in skin color. And they approached these people with a cultural understanding of Black that emphasizes things like filth and evil, whereas they defined white as symbolic of purity and beauty. Okay, so they're going into these interactions with already some cultural baggage. Europeans attempted to explain the difference in skin color. They derived some of their explanations from antiquity. Originally, European theories for Blackness focused on climate and sun exposure. Eventually, European scientists scrutinized these theories and noticed that other people around the world from similar latitudes and climates did not have that dark skin. Now, while these explanations for dark skin may seem ridiculous, they had considerable staying power. In 1861, for example, Mississippians seceded from the Union as part of the impending Civil War. And in their Declaration of Secession, they stated, "Our position is thoroughly identified with the institution of slavery, the greatest material interest in the world." Talking about cotton, they said these products are peculiar to the climate verging on the tropical regions. And by an imperious law of nature, none but the Black race can bear exposure to the tropical sun. Okay, so you see those ideas lingering at that time, about 300 years after European and African contact. Now, in the 21st century, these explanations for Black skin continue to have implications for health and medicine. In a study concerning self-skin exams, African Americans responded with less concern when confronted with pictures of melanomas. And so the study concluded that although melanoma in the African American population is less common than in lighter-skinned individuals, African American patients with melanoma often present or show up or bring it to attention at a later stage and are subject to a worse prognosis. And so as a result, the study proposed developing more educational materials concerning self-skin exams directed at this population in hopes of increasing or helping with early detection. Now, in the first moments of contact between European and sub-Saharan African people, they started to develop some other explanations as well. And those explanations also have some implications for the practice of modern medicine. Now, among the explanations, some Europeans theorized that African people descended or were marked with the curse of Ham, a biblical story of the disgraced son of Noah. They believed that this curse helped explain skin color. Now, in this explanation, theorists worked the problem kind of backward, okay? According to the curse, Ham and his descendants were destined to a future of servitude. Now, in ancient times, dark-skinned Ethiopians had been enslaved by the Romans, so maybe they linked slavery and Black skin as related there. Now, in these earliest constructions of racial difference, skin color was the most obvious and notable difference between these people, but it was not necessarily the explanation for racial difference, at least not until the slave trade intensified. Now, as the slave trade intensified, Europeans theorized other explanations, okay? While some people continue to point to black skin and the curse of Ham and things like that, others theorized that African people did not even descend from Adam and Eve. Okay, and that has some implications. In earlier centuries, so in the biblical story, right, God curses Eve and her descendants with childbearing pains. Okay, so as justification for the slave trade, this theory gained support because it argued that Black women did not suffer from childbearing pains, which made Black women suitable for endless productive and reproductive labor. For plantation owners, right, for masters and slavers, these theories justified putting enslaved women back to work immediately after childbirth. Right, and one justification of mass enslavement, a European theorized, their women are delivered with little or no labor. They have therefore no occasion for midwives than the female orangutan or any other wild animal. Thus, they seem exempted from the curse inflicted upon Eve and her daughters. According to a 16th century planter, in a fortnight after giving birth, this woman is at work with her pickaninny at her back, as merry a soul as any is there. Okay. Europeans also theorized, relatedly, that Black women breastfed with ease. So they recognized the difficulty of breastfeeding for white women, thus explaining the prevalent use of wet nurses among the European elite. But they believed that Black women could breastfeed as easily as any animal in the wild or in the field. According to one writer, when slave mothers go to work, they tie their young children onto their backs. While they work, they frequently give their children the breast across the armpits and let them suckle. Okay, so they're describing these Black women as like animals, right? With ease of childbirth and ease of maternal care. So with these descriptions, they're reconciling any misgivings they might have about putting mothers back to work at hard labor in the field. Now, once again, these theories have relevancy to modern medicine. According to the CDC, non-white women die in childbirth at much higher rates than white women. There are race-related environmental factors that contribute to this problem, of course, such as lack of access to appropriate and high-quality healthcare, delayed diagnoses, lack of knowledge among patients and providers about warning signs, and more. However, these ideas about race and pain threshold seem to play an important role in medical outcomes. So, for example, when comparing Black and white women with college degrees, who you would seem to have at least a closer, more relative equal access to facilities and knowledge, Black women still died in childbirth at more than 5 times higher rates. Okay. Now, in a 2007 study, researchers revealed that non-white women, especially Black women, were less likely than white women to receive epidural analgesia to control their pain, right? Which has been recognized, childbearing pains, right, recognized as one of the most painful moments in women's lives. Okay, so in a 2016 study, researchers revealed that African Americans were systematically undertreated for all types of pain relative to white Americans. And these biases resulted in less accurate treatment recommendations. Okay, so in some cases, these stereotypes about Black bodies and pain threshold, that predated 15th century contact have still altered medical practices for 500 or more years. Now, among the many theories that justified or that explained racial difference, European travelers to Africa and white plantation owners in the Americas focused on Black sexuality as a sign of barbarism. All right, they described African people as lustful. They described them as beastly, unable to control their urges with reason. In short, according to one writer, in Ethiopia, the race of men is very keen and lustful. So in all sorts of things, travelers described African people as especially voracious. The people of Sierra Leone are very greedy eaters and no less drinkers, and so on, okay? So like other medieval stereotypes, the portrayal of Black people as especially sexual also has a legacy. Such linkages between African Americans and sexually transmitted diseases, which for a long time has been explained by professionals as a result of their inability to control urges. Ultimately, it was extremely powerful in its connection to the creation of the myth of the Black Beast Rapist. This is a myth that justified punishments such as castration for enslaved men, rape of enslaved women, and then years later, justified segregation and lynching during the Jim Crow era. So I want to talk a little bit more about specifically African Americans in slavery and how their treatment by masters and slave traders, but also medical professionals, has implications for the practice of medicine today. And so as a fundamental part of the slave trade, potential buyers subjected Black bodies, Black people to medical inspection and invasion that has left a legacy of distrust. Among the many factors that determined a person's value, physicians performed medical exams to evaluate whether individuals were, quote, sound or unsound. Okay, so medical exams played a major role in the commodification of bodies. They not only helped slave traders and purchasers, they helped insurance companies too set values on these people. As part of the exam, unsurprisingly, enslaved people were poked, prodded, and examined, not only by doctors, but by potential buyers. On the auction block, for example, auctioneers instructed enslaved people to disrobe, turn around, and otherwise demonstrate their, quote, soundness to the crowd. Now, although all enslaved people were at least subjected to this treatment, young men and women underwent the closest inspections. When purchasing enslaved people, traders and enslavers considered future increase into their calculations. As a result, enslavers, traders, and medical doctors paid careful attention to gynecological health. In fact, historians have argued that the field of gynecology grew out of slavery and attention to Black women's bodies. The founders of the field conducted most of their research on enslaved women. Now, after death, right, from the cradle to the grave, enslavers continued to view Black bodies as valuable. They trafficked these bodies as part of an emerging cadaver trade, upon which American medical knowledge, which at the time was considered pretty backward, especially compared to some European schools, in part because there was not a very robust cadaver trade in the United States. But the cadaver trade that did exist was based in large part on a final sale of enslaved people. Often, enslaved people sought medical treatment from Black healers on in their own communities because they distrusted masters and white medical practitioners. But when they did seek white healers, they suffered from humiliating examinations and experimentation. During slavery, white masters often experimented on enslaved people with cruel and sadistic medical treatments. Landon Carter, who was a planter in colonial Virginia, had a sadistic fascination with medical science at the time, in particular purges, emetics, and enemas, which he famously administered in incredible proportions. So when enslaved people fell ill or faked sickness, which was a common form of resistance, he bombarded them with these so-called treatments. Now, Dr. Benjamin Rush, famous doctor from the Revolutionary period, performed experiments on African Americans in an attempt to explain their Black skin. Working with a free man named Henry Moss, for example, Rush purposefully blistered Moss's Black skin in an attempt to induce skin color change. Obviously, it didn't work. Then Rush hypothesized that Black skin resulted from a disease similar to leprosy and continued to experiment. Among many research projects, Dr. John Robertson of England theorized that because of climate, African men and women entered puberty earlier. So of course, they directed these theories to, like I said earlier, supporting African women's and men's so-called enhanced sexuality and childbearing capabilities. So despite the fact that enslaved people lived in abhorrent conditions, medical doctors often explained their poor health as not a result of those poor conditions, but instead as their own fault. Briefly, I want to talk about also the medical spectacularization of African American people and African people. Medical professionals often put enslaved people on display for the public. For 5 years, a French scientist displayed a woman from South Africa. People paid to touch and study her body as she stood on the auction block. After her death, the same scientist took a plaster mold of her body, which he put on display at the Paris Museum of Man, and her body remained on display until 1974. Additionally, doctors performed public autopsies for students and other audiences. Masters found that selling dead bodies to science, like I said, was a final opportunity for profit. But beyond that, then the purchasers continued to profit from these bodies with public dissections. As of 1835, Joyce Heth was an enslaved woman in Kentucky, but her master sold her to 2 promoters who marketed her as the enslaved nurse to George Washington. Then P.T. Barnum bought her, and he claimed that she was 161 years old, and then upon her death, continued to display her, including a public autopsy, which 1,500 people paid 50 cents to attend. So finally, I want to talk briefly about the treatment of African Americans from a public health perspective, but I will leave most of that topic to Dr. Comiskey. I want to highlight some of the notable events in public health that, among others, have contributed to lingering Black distrust for the medical profession. In these 3 cases, the examples concerning people were free people, or at least for the most part. All right, so we're back to Dr. Benjamin Rush. In 1796, yellow fever epidemic hit Philadelphia. Dr. Rush, among others, other doctors, believed that Blacks were largely immune to the disease, and the epidemic provided them with a horrific opportunity to test some of these theories about racial difference. Now, with the premise or the understanding that Black people were immune to this disease, the city's Black leaders organized to have some people stay behind and help nurse sick white patients to health. But it soon and tragically became apparent that Black people did not have immunity to this disease. During the Civil War, Black soldiers received second-class health care by standards of the period. The Black units lacked enough doctors, and the doctors in Black units tended to lack skill and compassion. According to official policy, each regiment was supposed to have one surgeon and 2 assistants. But by the time the U.S. Army created the U.S. colored troops, most available doctors had already been assigned to white units, many of them for a few years already. The U.S. colored troops suffered higher mortality rates, which doctors blamed, right? Not on conditions on the battlefield at all, of course, but instead on weakness inherent in the Black body. Now, sometimes lower quality care resulted from genuine lack of experience with Black bodies. At this time, I'm talking about things, that would be difficult to untrained eyes, like detecting rashes, smallpox, measles, and chickenpox on Black skin. Whether intended or not, however, the lower quality care given to Black soldiers led to a lot of distrust. It did not take long for Black soldiers in the Civil War to lose faith in their surgeons. And then beyond that, right, some surgeons treated Black soldiers in sadistic and cruel ways, in part based on that theory that African Americans had higher pain tolerance. For example, a surgeon actually was court-martialed for refusing to operate on a soldier who had shrapnel in his foot because he did not think the wound was causing the soldier any pain. So finally, I want to wrap up with a famous example about the Tuskegee syphilis study. 1929, there was a private nonprofit organization that started a program to actually treat syphilis in Black Southerners. Among the places they chose Macon County, Alabama, where 40% of the Black population tested positive for syphilis. Now, as part of the program, 1,400 men, women, and children received treatment for syphilis. In September 1931, however, because of the Great Depression, state governments lost funding or stopped funding the program. They stopped matching the state funds to make these treatments happen. So the program stopped. But in 1932, the Public Health Service took control of the entire program and made some changes. They only recruited men. They conducted the program as a study of untreated syphilis. So as part of the study, men could not receive any treatment, even as it became available through the development and distribution of penicillin. So although the Public Health Service did not infect these men with syphilis, and Dr. Comiskey might talk a little bit more about this later. They did allow it to go untreated for many decades, resulting in death, blindness, gait disturbance, psychological problems, and more. The study continued until 1972. So for 40 years, these people did not receive treatment if they survived that long. It ended because of outrage from a newspaper feature. So it took 40 years to end this study, despite the fact that Congress had to reauthorize funding for it time and time again. Right, so there were opportunities many times to end it. Also, during this time, the United States had signed agreements, international agreements, many of them after World War II, to stop things like this, to stop human experimentation without consent. So I think you can see that, over this whirlwind introduction to about 500 years of history, there have been many misunderstandings and lots of mistrust in this community toward medicine and the practice of it. But I'll stop there and turn it over to Dr. Comiskey.
Can everybody hear me okay? Okay, great. I'm gonna just flip over and share my screen. All right. So it's such a pleasure to be part of this, and I'm really grateful to Ms. Blackman and to Professor Howard Baptiste for inviting me and Mark. It's a pleasure to be here. I want to start with a huge caveat, which is this is an enormous topic, right? And we could spend ages on this. At the end, I think on both of our last slides, Professor Johnson stopped before sharing his bibliography, but I think both of us have a link to the African American intellectual history syllabus on racism in healthcare, which I highly recommend. So please don't take absence of a topic in these talks to suggest that it's not important. But I thought I would take this opportunity to sort of reflect on the flip side of what Professor Johnson talked about, which is ideas about the Black body is different, to actually talk about how ideas about color blindness or a lack of difference actually has also caused harm in healthcare in ways that are arguably even more insidious than the sort of outright racism that characterized some of the earlier really abuses. And I'm going to start with three news articles that I found just this summer, actually in the last month plus. So the first was a headline, Black newborns more likely to die when looked after by white doctors, which was shocking. So that was the first one that caught my eye. The second was the racist roots of the BMI measure harming Black women. The third was particularly related to COVID, how a popular medical device, the pulse oximeter, encodes racial bias. And finally, this one was just yesterday, dermatology has a problem with skin color. And so just in the last 5 weeks, we've had major stories. And I should say each of these is responding to publications in the scientific literature. And I'll give you some of those citations as I go. These were the things that came up like in my Facebook feed. And then I clicked through and started looking at where they came from. But each of them really reveals a different way that, can you hear my dog? That medical expertise has been encoded with ideas about race and about Black and white bodies in ways that consistently lead to harm for Black patients, in ways that maybe appear accidental and often to some extent are accidental. It's not deliberate, but they're deliberate in the sense that we've deliberately not fixed them. And so that's one of the things that I want to talk about. So I want to start out, though, with this story about Black babies more likely to die in the care of white doctors. And the study that showed that, it's interesting because one of the things it doesn't really have an answer for is why. Like, what is it, right? It's certainly not, they didn't find abuse by these doctors. They didn't find negligence. So they're still really reckoning with it. But what they found was a clear statistically significant difference in the survival of newborns, depending on what they called racial concordance with the physicians or racial discordance with the physicians. And as a historian, what I started thinking about after that is, well, why are so many Black babies cared for by white doctors? And part of the reason is that there are disproportionately few Black doctors in the United States. Well, why is that? Well, part of it goes all the way back to 1910. And of course, as Professor Johnson suggested, far back further than that. But there's this critical moment in the history of medicine that's actually often celebrated, and that's the issuing of the 1910 Flexner Report by Abraham Flexner. So as a little bit of context, I should say that before the early 20th century, medical education in the United States was totally unregulated. I could start a medical school in my kitchen, and as long as I could print degrees and collect tuition, you could be an MD. So there was a real problem. There was no consistency in the quality of medical education. When you needed a doctor and you found somebody, you referred to somebody and they said, oh yes, I have an MD, don't worry, I know what to do. You had no way of knowing whether they had been rigorously trained with clinical practice and laboratory facilities and basic science education, or whether they had attended a few lectures, which might not even mean showing up for the whole thing, might mean sleeping in the lecture hall and gotten a degree. And the Carnegie Foundation was really concerned about that. They were concerned about the quality of medical education and the consistency of medical education. So they hired Abraham Flexner to go visit all 155 schools of medicine in the United States and in Canada at the time. And of those 155, 7 were primarily for Black students. They admitted Black students because medical education, like virtually everything else in the early 20th century, was segregated. So Flexner spent 10 years traveling around to all these schools, reporting on what kind of laboratory facilities they had, how many faculty they had, what kind of credentials the faculty held, what kind of prerequisites they required of their students. For example, at many schools, it was actually there was no test of whether students were literate or not before they started medical school, let alone whether they knew advanced mathematics and chemistry and physiology and anatomy. Most schools, again, and Professor Johnson alluded to this as well, cadavers were really difficult. So many students were not trained with cadavers and human anatomy. And many had no connection to a hospital or another clinical practice where students could actually observe clinicians doing their job. So the quality of medical education in many places was really poor. So Flexner published this report in 1910. And the Carnegie Foundation used it to determine which schools they would fund or not. And the Carnegie Foundation was influential enough that their recommendations actually carried her out to a lot of places. So basically, once you got a bad rating in the Flexner report, it was really hard for your medical school to raise any kind of money or get any kind of sort of reputation. And so basically, in the next 15 years, the vast majority of those schools actually closed. By 1923, there were only 66 medical schools. Remember, there were 155 to begin. And of the 7 that educated Black physicians, only 2 were still open, and those were Howard University and Meharry Medical College. So I want to stop here for a moment, because on the one hand, the idea that these sort of illegitimate degree mills got closed down might not seem tragic. It doesn't seem like a bad thing that medical education had some quality control. But of course, the alternative to shutting these schools down would have been to giving them the resources to develop the facilities they needed to deliver good education, particularly looking at medical students who were not well served in the existing institutions. And I should say, I don't have the numbers on women's medical colleges, but much like Black medical colleges, they were decimated by this report. And Flexner really argued that there was no need for Black medical schools or women's medical schools because they should all just go to the same medical schools, which on paper sounds great, right? Of course they should. But they were not, in fact, admitted to many of those schools, or if they were admitted, they were held to an entirely different standard. They were abused, they were made to feel unwelcome, they were not competitive for residency. So this sort of Flexner's refusal to acknowledge that these schools that catered to women and Black medical students actually served a purpose that was not being met any other way. The other thing that Flexner was really blinded to was why it was important to have Black physicians. And he argued that, okay, yes, they did need what he called Negro doctors. And there's this long quote here: the practice of the Negro doctor will be limited to his own race, which in its turn will be cared for better by good Negro physicians than by poor white ones. But the physical well-being of the Negro is not only of moment or significance to the Negro himself. 10 million of them live in close contact with 60 million whites. And then he goes on to basically say, so we should care about educating Black physicians because it will be better for white people if they are not exposed to the diseases that are rampant in the Black community. And so he basically said that we should train physicians primarily in hygiene and sanitation to prevent the diseases that afflict their communities from getting into white communities. So he actually advocated against training Black physicians in surgery. He just didn't think it mattered as much. So making sure there was a robust, accessible educational system for Black physicians was not a priority for him. He did not think it was important. This is a study that, when I read this discordant care thing, I found a study that was conducted a few years ago, or no, this year, that actually did something historians are a little bit uncomfortable with, which is like a what if this thing hadn't happened, or we sometimes call it a counterfactual. What if Flexner hadn't written this report and all these schools hadn't closed? Which, you know, hard to say what would have happened, but they basically extrapolated out from all these schools that educated Black medical students and estimated that the schools that closed would have trained an additional 35,315 physicians, and that in 2019 alone, you would have had 29% more graduates in medical schools. So let's assume that they didn't just keep turning out, that all these schools didn't just turn out bad doctors, but if they actually had been invested in, if the Carnegie Foundation had decided to invest in these schools, make them capable of training qualified and you know, capable doctors, that the disparity in terms of how many Black physicians there are would be really different. And we still don't totally know why it matters that there's a Black doctor caring, or a white doctor caring for a Black infant, or not, or the other way around. I mean, I think we can all speculate. It's not that hard to come up with some reasons why that might be. And a lot of what Professor Johnson described about ideas about the Black body, about pain, about recognizing signs of disease, signs of ill health are in there. But what we do know is part of the reason there are so many Black babies cared for by white doctors is that Black people did not have access to medical education in the same way that white people did for a very long time. And even today, if you talk to physicians that are educated in predominantly white institutions, you know, you'll hear that their experience is very difficult, that they don't necessarily have access to the same training opportunities, that they're not made to feel welcome, they're not made to feel like they're a part of this. So it goes way back. So that's the first news story, and a little bit of historical context for it. The second one about the pulse oximeter. So many of you may have heard about the pulse oximeter for the first time. Sorry, I got a little bit ahead. I should have a blank slide, but I don't. So the pulse oximeter is a device that goes on your finger and measures the saturation of your blood with oxygen. And it's basically a measure of like, are you getting enough oxygen? You know, if you've ever gone to the emergency room with shortness of breath or difficulty breathing, the first thing they're gonna do is stick one of these on you and decide whether you just feel like you're short of breath or whether you're really not getting enough oxygen. With COVID-19, this has become much more commonplace than ever. Early indications found that patients whose blood oxygen levels got below about, I think they decided 88, 89 was the threshold at which they really needed to be put on supplemental oxygen, and had much better outcomes than patients that were allowed to just continue having difficulty breathing. But this is an area where very small differences make a big difference, right? The difference between 88, 89, and 90. So why does that matter? Why does race play into this? This is another example of how sort of race color blindness can be problematic, because the way a pulse oximeter works is by actually passing light through the skin, and it is scattered differently by oxygenated blood than by non-oxygenated blood. And we have now reached the limit of my physics knowledge of optometry, of optics and how that works. I can send you a citation that has lots of Greek figures in terms of how that works, but that's how it works. And what has been anecdotally observed and measured to a certain extent is that when you go to the emergency room, or if you get COVID and they tell you to get a pulse oximeter, they will warn you, don't wear dark nail polish because that screws up the reading. Which led a lot of people to say, well, wait, does darker skin change the reading than lighter skin? And it turns out it does. It's still not entirely clear how much, but what they've found is that based on much more invasive blood gas measurements that really are a lot harder than putting it on, that for the darker your skin, the more the pulse oximeter overestimates your blood oxygen levels. And now we're not talking about huge differences, but it could be the difference between 88 and 90, for example. Because these instruments were calibrated using almost exclusively white patients. For many years, medical research excluding a few really outrageous, not a few, many outrageous and abusive experiments, such as the ones that Professor Johnson described. The sort of run-of-the-mill testing of pharmaceuticals, of medical devices, of interventions, a lot of times treated the middle-aged white man as the normal body that you could make standards for. And then everybody else was sort of a deviation from the normal that you wouldn't have to worry about too much. So people are starting to observe that the pulse oximeter, which has been normed to the middle-aged white man, actually doesn't perform as well in darker skinned people. This can make a difference because, for example, if the protocol is that somebody gets supplemental oxygen when their blood oxygen level gets down to 88, then somebody with lighter skin who actually is at 88, the pulse oximeter will say 88. Somebody with darker skin, it might say 89 or 90, which means they're less likely to get supplemental oxygen. It also means that Medicaid will not reimburse for supplemental oxygen or intubation. If the pulse ox says that the oxygenation is too high, they're less likely to be admitted into the ICU. So there are all these consequences of that small number that are, and they get added on as the study, one of these articles reported, to all of the other ways in which race determines the quality of care that people get. So it's not just that one thing, but it's one thing on top of many. So what do providers think about that? That was what Amy Moran, the journalist, asked. And she found that for some of them, they couldn't even handle it, right? And I do think it's important to keep in mind, this is in the middle of a crisis, right? The doctors that are dealing with these numbers, they are working very long shifts. They're very worried about getting infected, infecting their families. It perhaps is asking a lot for them to step back and think about the systematic determinants of instrument calibration and how that, affects things. But others have pointed out that actually that's really worrisome, because what we have seen is African Americans end up with severe COVID-19 at much higher rates proportionally to white Americans, and are much more likely to die of COVID. And so if this is one part of that puzzle, it's a part that it would really behoove us to look more closely at. And I would say that the pulse oximeter is more the rule than the exception in terms of how supposedly objective instruments that, the pulse oximeter isn't racist, right? It doesn't have any ideas about race. It's a device that measures optical reflection and refraction. And again, physics, not my thing. But because of the way it has been coded and because of the way it's interpreted, it actually is imposing racist ideas on that. So that's the pulse ox. And I know I'm going really quickly. Somebody flag me down if you want me to slow down, but I do want to make sure we have a lot of time for questions. The pulse oximeter is by no means the newest one of these, and it's not even the newest or the oldest, and it's not even the oldest about breathing. If you're looking for some light reading, I highly recommend Lundy Braun. She's a historian, and she wrote a book on the history of the spirometer. And if we were in a real room, I'd ask you to raise your hand if you have asthma and have ever had to use a spirometer. Today, they tend to look like this. And the idea is that you breathe in as much as you possibly can and then exhale as forcefully and as long as you possibly can. And the idea is to measure basically your lung capacity, right? How much air can you expel? And that's a measure of how well your lungs are functioning. So the spirometer is actually a pretty old instrument. It was invented by John Hutchinson. He first demonstrated in 1844. I say he invented it. He was credited with inventing it. A bunch of people developed very similar instruments at around the same time. But he demonstrated it and published on his findings. And this is an illustration of what it looked like when he first got it. You don't have any plastic tubes. And he described it as a measurement of vital capacity. He started out with lung capacity actually and switched over to vital capacity, which suggests that he thought there was something a little more to it than just how much air your lungs could carry. But that gets us into a whole other area of medical history that I'm gonna table for now. And he was inspired by the work of Adolphe Quetelet, a Belgian statistician who measured large groups of people, to take his spirometer out and measure lots of different people to see what different people's vital capacity was. But when I say lots of different people, again, I'm mostly talking about European white men, because he went to soldiers, public sector employees, and industrial workers. So these were primarily white men in, say, their teens, 20s, maybe 30s. But he got a really wide range of them. And he was looking for correlations between vital capacity and height, weight, chest size, overall health, likelihood of getting tuberculosis, all these different things. He was trying to figure out what he could measure with this device. And this is in some ways a sort of an example of when all you have is a hammer, everything looks like a nail, right? He invented the spirometer and he was going to answer every question he possibly could with the spirometer. It wasn't terribly useful clinically, but it got applied a lot in physiological research, right? It was a way in a period when people were really interested in understanding what happened inside the body, but didn't have very good ways of directly observing the inside of the body, of a living body, I should say. This was a way to get sort of an indirect look at what was happening inside the body. So it was really popular. But it wasn't until the Civil War that it got taken up widely in the United States. And what happened during the Civil War was researchers realized this was an opportunity to get physiological data on a larger group of American men than ever before. And so in 1869, Benjamin Apthorpe Gould published a book called Investigations in the Military and Anthropological Statistics of American Soldiers, in which he described, among other things, the spirometry results of Black and white soldiers. And you can see here, he's actually ranked them in a ranking that's really consistent with 19th century conceptions of race more broadly. And this is the age, the sort of high age of scientific racism, right? Racism that is couched in the language of science, in the language of objective measurement, in the language of fact. And so what he found was that Black soldiers consistently had a smaller vital capacity as measured by the spirometer than white people. This was consistent with ideas, for example, about susceptibility to tuberculosis, to Black people just having quote unquote weak lungs, but this was considered an objective way to measure a difference between the races. What has happened since then is data like this, which differentiates between white and Black patients, has actually been coded into spirometers. So when you get measured by like a spirometer up here on the left, it's digitally, the person taking your spirometer measurement actually goes in before you breathe in to enter your race. Sometimes they'll ask you, sometimes they'll just quote unquote eyeball it. And that basically calibrates what should be normal for you, right? Because the results are going to be you're at sort of 95% of what you should be, 92%. And if you are Black, then that normal is going to be lower than if you are white. Again, this is based primarily on observations from the 19th century and then sort of reiterations of this. And so once again, this is sort of a way that a supposedly objective instrument has actually been encoded with the racist values of the people that have invoked it. And so there are still debates going on in, for example, in allergy control about, is this a reason that perhaps Black children are being undertreated for asthma because their sort of percentage of what's normal is considered to be higher than what it would be if they were white. My dog is very upset about racism and spirometry. So that's just another example, and I highly recommend the book. She also wrote an article, it's in my bibliography, but it's a much longer story, but that's the like however many minutes version I'm gonna give you. There's some quotes that you can see about sort of why that matters, and particularly how it got globalized. So finally, the BMI. This is maybe my favorite. The body mass index, again, a supposedly objective tool to measure basically whether you're too fat or not. And if you have been to a doctor in the last 25 years, I can almost guarantee they've calculated your BMI. You can do it on Google. It determines whether you're healthy, overweight, extremely overweight, or obese. And like race, BMI has been correlated with higher morbidity and mortality with COVID-19. It was one of the earliest observations that was made from the large groups of ill people in Europe and then in New York City. So what does that have to do with race? This was an article that was published in July, and I put the headline here because it really says it all. The BMI is racist and useless. Here's how to measure health instead. She does not mince her words. And Christine Byrne wrote this piece, and you can check it out. It's pretty interesting. She does a good job of sort of going over the history of the BMI, about which there's not a good scholarly text. Like a historian has not written a good history of how the BMI came to be, but there are some accounts out there. But basically it goes back to Cited. He's the same guy that inspired the inventor of the spirometer. He was a Belgian statistician. And he was on sort of a quest to define what he called le moyen, or the average man. But average didn't mean for him what we sort of think of as like run-of-the-mill average. For him, it was the ideal man. And he went around measuring all kinds of people in all kinds of ways to try to figure out what was the ideal man. And he observed a ratio between height and weight that became called the Cited index, that he thought characterized le moyen, an ideal ratio between height and weight. Now, again, this was mostly measurements on white European men. and primarily kind of middle-aged white European men or working-age white middle men. It was adopted in the early 20th century by life insurance companies as a factor that was, they thought, a useful predictor of who would become ill and die and who would not. But it didn't really get picked up for individuals until the 1970s. And that's the first time that you would actually get, your BMI would be calculated in the doctor's office, and you would be instructed to try to change your BMI. So why does this matter? Well, it turns out that that sort of ideal ratio that still determines what's considered normal, again, it doesn't necessarily apply to Black people as much as to white people, to women as much as to men. Women tend to have a higher percentage of body fat. And the BMI, a number of studies have shown, is a terrible predictor of morbidity and mortality. It's not well correlated, for example, with a lot of factors that determine health. It does have strong correlations with some things, but a lot of people wonder whether it's more of a proxy for other factors, right? People that have access to health facilities, to nutritious food, that are able to keep a sort of svelte body might also have access to other things that would improve their health. So whether we're kind of blinded to this more complex relationship. Sabrina Strings has done some really interesting research on the history of not so much the BMI, but the idea of fatness in general and its connection to race. And she argues that, as Professor Johnson said, in this period when Black bodies were being exhibited as spectacle, that fatness was really associated with savagery, and that fatness came to be a marker of lack of control, of lack of the ability to control one's appetites, as opposed to, as it had been in earlier times, prosperity and wealth and the ability to get food. And so in the 19th century, it wasn't about health, it was about sort of virtue, right, and character. And then into the 20th century, as people start talking about fat more as a health issue and less as a virtue, those values really stuck, and that association with race stuck. And she goes into far more detail than I will here, but she's done some really interesting work, including being so she says, during the 19th century, the era in which scholars have shown the anti-fat sentiment in the United States was on the rise. The fear of racial others played a critical role in the growing horror surrounding corpulence, which is just such a pithy statement. This is from an article she published in the New York Times this spring in May, after she was asked to join a task force on understanding why Black people were dying of COVID so much more than white people. And she recounts the experience of being on this panel and being asked this question and saying, slavery. The answer is slavery. And then this article, she really elaborates all of the different ways that the experience of slavery and the subsequent experience of segregation, of Jim Crow laws, of the exclusion from opportunities that white Americans had, financial, social, educational, have continually put Black bodies in greater jeopardy of ill health. And that COVID is one more of many things, that what you're looking for isn't, a special characteristic of this virus that is singling out Black people, but it's one of many things that highlight the vulnerability of Black Americans to ill health. And I would encourage you to read the article. It's very interesting. It's very historically informed and really thoughtful. But what all of these examples have made me think about is that they all, to some extent, reflect an assumption that there is an objective difference between Black and white bodies, right? And there's a whole lot of discussion about that, right? Is race real? What is race? Is race biological? Is it social? And the American Public Health Association has started to weigh on this, recognizing that race, according to them, is a social construction. It is real socially, but it has no biological basis. But racism is very much real. Racism refers to a social system that reinforces racial group inequity. And so as we evaluate outcomes between Black Americans and white Americans, what we shouldn't be looking for is a biological sort of Rosetta Stone of why this is happening. But what is it about us as a society, us as medical professionals, us as public health professionals, that are making Black Americans so much more vulnerable to the various pandemics, endemic conditions that place them in jeopardy of early death and greater suffering. We could have talked about urban segregation, about environmental exposure, and the ways that those have determined Black health. We could go on and on and on, and I would encourage you, there is here is a link. I'm sure we can share the link to the Anti-Black Racism in Medicine syllabus. That is a 16-week syllabus starting with, sort of Europeans encountering Africans and going right up to the present. And of course, we're here for Q&A. So I'm going to stop now and let you guys chime in a little bit. But thank you again for having us.
All right, are we ready for Q&A or?
I think so.
Okay. This is the time, guys. If you feel comfortable voicing your questions, please feel free to put them in the chat, but we'd love to hear from you and have your questions answered by our wonderful speakers.
Can I unmute myself real quick and ask my question?
Yeah, no, totally.
So what was talked about in the previous slideshow about like how literally like 5 articles came out within the last 3 months about racism in the medical field. There is one thread on Twitter right now. Well, it was a CNN report and then it turned into a thread of like Black pre-meds and like Black pre-dental students and even like Black dental students and Black medical students saying what you said about how Black babies are more likely to survive and also live healthier if they're being delivered by a Black OBGYN compared to white OBGYNs, because you have a 3 times more likely chance of dying due to like medical racism. And then there was another one going around, I forgot what it was about, but it was, oh yeah, that's what it was about. It was about like how Black people, particularly who go into medicine, don't want to specialize. They want to do primary care. And would one of you like to touch on why is that?
I think that there's 2 main reasons, although this is, something I haven't totally looked into, but I think there are 2 main reasons. One is that Black physicians tend to go into, or Black medical students tend to go in knowing that their communities are underserved, right? Feeling a real sense of calling to serve their community as a whole, and often very much aware that the resources of a larger community have gone into getting them where they are, right? That people have made sacrifices. And family practice or general practice is often the kind of care that communities most need or most acutely feel the absence of, right? People don't have GPs, people don't have a primary care provider. I think that's one reason. And that's the good reason, right? Like they're going into the field of medicine that they will find most rewarding. The bad reason is that the more elite the specialty, the more exclusive it is. And in many ways, the more hostile it can be to people that don't look like the people that are already in it. And anecdotally, from working at Johns Hopkins, I mean, I can tell you this there are a lot of old white men wearing their school ties that don't particularly want to train people that don't look like them or don't know how to, and frankly have a lot of racist ideas about the intellectual capacity of some of their students. There's a lot of negative prejudice about things like affirmative action, right? A lot of things that they won't say officially, but they'll say amongst themselves that they don't believe that, Black students deserve these places. So I would say there's both of those. And I'm sure that there's many more complex reasons, but those are the 2 that really come to mind, sort of feeling called to general practice and feeling unwelcome in specialty practices.
We had a question in the chat about sharing the slides, so I believe we'll send those along to all the participants. And then for those of you watching later, we will have the links posted in the comments. Any other questions?
I have a question.
Okay, go ahead.
So as somebody that plans to go in the medical field after undergraduate, how do you feel like I can prepare for what I'm about to experience as far as like bias from my teachers and my cohort as well?
I don't know that Professor Johnson and I are the best qualified people to answer that question. Yeah, I mean, I think, I I think knowing the history of why things are the way they are can sometimes take away some of the power that they have, right? Understanding that they're that way because people have made choices to make them that way. I would also research the schools that you go to, right? Some schools have a much better track record than other schools. And the ones with the biggest names are not always the places where women, for example, are likely to be successful, or where people of color are likely to be successful. You know, talk to people who have gone to different schools, find out what their experience was, get the dirt, go beyond the test scores. I would say all of those things, you know, talk to your mentors, what were their experiences, and recognize that I think a lot of particularly white male physicians will not understand that their experience would not be typical of every student entering. But I don't have any firsthand experience of going to med school in any capacity.
I'll just add to that, Dr. Kaminsky. I think, Trinity, first, I think we're excited about another Black professional entering the field. So we welcome you. We'll be ready for you when you're at that stage in the application process. And the information she provided, I think is spot on, which is research those institutions, find out where people have been successful. It's not always about a name or a scholarship or a dollar amount that's attached to that program. You want to make sure that you have a very worthwhile experience. And there are programs out there that graduates speak very, very highly of, and it becomes really kind of word of mouth and a good referral system. I think there are a number of summer programs that you could get involved in, and I'm sure Ms. Teresa can help maybe direct you to those opportunities, or working with your professional advisor. And that's a great opportunity for you to get connected to maybe a week or a 4 to 6 week summer program where you can be on the campus, you can meet the faculty, you can just learn more about that program. And I would also say just really get into the literature so that you see, as Dr. Kaminsky said, what is historically where that perspective is coming from, but also finding ways and kind of safe spaces to navigate that pathway so that you don't necessarily have the same experience of others. I think connecting with really good mentors here at UTC in the community and other spaces where you can really share your ideas, you get your application materials together, and you feel very supported in the process. So we've had UTC students, Black male and females, who have gone on to medical school in the health and medical field, you know, for years. And so I'm sure that there's a way that we can collectively share their experience and maybe get you in contact with them so that you can start early in terms of formulating a pathway so that you have a really good experience. Not that it won't be hard, because it's hard for everyone, but we want to make sure that you get the training here as an undergraduate student. So whether that's research dialogues or other opportunities to engage here on campus, but also ensuring that you have what you need to be successful after you leave here.
The other thing I would add is both of us gave talks on sort of the bad parts of the African-American experience in medicine, but like there are amazing role models out there. There are stories that I think historians, particularly historians of medicine, are just beginning to be better about telling about particularly the history of Black women in medicine, which are fantastic, and which, you know, I think we underestimate the value of a role model, of a story that speaks to our experience, and they're out there. And so to some extent, unfortunately, you have to dig a little harder for them. But again, I think that syllabus, among others, has stories of why those experiences tend to be more invisible, but they're there.
And stick with the series too, Trinity. I mean, that's really what Teresa's and our brainchild was, is to have a number of programs in the evenings that address this very thing. So two of my really good friends, one has a PhD in immunology from Cornell University, from an Ivy League, and he went to historically Black college in Mississippi. And so he's very successful. His wife, one of my good friends, she's a dentist. She went to FAMU in Florida, went to Meharry, not too far from here in Nashville, for dental school. So they both have very different pathways of how they got to where they are. So I would say continue to stick with the series too, and I think you're going to hear about what Dr. Kaminsky alluded to, which is the hope and the opportunity and the experiences that are going to be a little bit more positive coming forward. So you'll get to hear directly from Black medical professionals who are currently working in the field.
Definitely. And to add on to that, ways you can look and sort of filter schools is looking at schools that host RAM clinics remote area medical clinics. Those clinics are really focused on a lot of diversity initiatives. So schools that are not just saying diversity is important to them, but they are actively pursuing ways to provide healthcare to underserved communities. That shows that there is a dedication to providing healthcare to all people. And that translates into educating all types of people to be healthcare providers. Tennessee State University is one of the few schools that has an OTPT student-run clinic. It was completely started by students, not medical school, but there are these pockets of schools that you don't see on, the Forbes best list or anything like that, but they're fantastic programs, and their initiatives and their actions speak volumes as to where the heart of that school is. Because anyone can say diversity is important to them, and anyone can say that they support, underrepresented communities becoming healthcare practitioners, but are they actually doing it? So that's a good place to look as to what are they actually doing.
And also, Trinity, like, I wanted to tell you about some opportunities with some major hospitals and also like medical schools that are actually giving back to Black and Brown students who want to pursue medicine. So like Duke has like a 6-week or 8-week program where you go to Duke University School of Medicine, and you can you learn about biochemistry, you learn about some physics, some things of that nature, and it also like helps you with they also help you with like getting your application ready. And then they also do like, I think it's like twice a week you like go with a particular clerkship, and you can do like emergency medicine, OBGYN, you can do pediatrics, and that's like what you would do. And that's what they're trying to do, is like see more Black and Brown people, particularly women, in the field of medicine. And like, I think that all you have to do for that program is just apply, and you have to have like at least a semester of chemistry, so you should be fine.
All right, thank you guys. That was like a lot more than I can handle, but I really appreciate it.
Any other questions? Anything anyone wants to ask in the chat?
I had one question for our panelists. Considering the types of research that you all do, and we kind of talked about this before our formal talk this evening, how do you recognize kind of your own identity and how that works with the research that you study?
Do you want to go first, or do you want me to take that one?
You say it one more. You say the question one more time.
Sure. Particularly as individuals who, I'll assume, and then you all correct me, who do not identify as Black, how do you utilize, address your own kind of racial identity, and then studying the experience of Black thought and experience? Black thought, yes, the experiences and areas of Black thought.
Yeah, I think one thing that our discipline, the Department of History and the study of history, thinks about is that everyone we study is in some way foreign to us, because we're studying people from the past, and it's almost like going already to even if you say the United States, it's like going to a foreign country. And so in that way, the methodologies, just the way we practice it, just the study of primary sources kind of helps us in a way get there. But yeah, I benefit mostly from, events like this one, and listening to scholars, people of color talking about it and following their lead on a lot of it.
Thank you.
Yeah, it's something I've been thinking a lot about, and I am grateful to the people of color in my life and in my profession who have pushed me to think about it and helped me think about it differently. My main role in the history department is as a historian of Africa, and the African Studies Association, which is my main professional body, has been having a bit of a reckoning in the last 5 years about the fact that it has historically been a very racist organization that specifically and deliberately excluded African Americans as being the wrong people to study Africa. And so one of the things that I've been thinking a lot about is what have we lost because of that, right? What insights, as Professor Johnson said, there's definitely a degree to which everybody in the past is foreign to us. But I also think that my background, my personal experience, my, all of the ways that I've been acculturated to thinking about the world affect the kinds of questions that I ask of those sources. And people that come to these sources with a different background think of different questions, right? And I see that time and again when I'm interacting with other scholars with different backgrounds, that they think to ask different questions, or they'll read different silences differently, right? They'll notice absences that I don't notice because they seem natural to me. And so I, like Professor Johnson, I mean, a lot of it has been listening to other people, listening to people who represent different backgrounds, listening to my colleagues of color, and then also thinking a lot about what can I do here at UTC? What can I do in my professional associations? What can I do as a citizen of the United States to make it less likely that our profession will be as white in 10 years and in 15 years and as 20 years as it is now. And I think that will be to everyone's benefit. I think we will be stronger as a discipline with that. But it's a challenge, and it's uncomfortable sometimes, and I'm sure it's uncomfortable for some of my students sometimes.
Thank you for that. The reason I asked you all that is because I'm sure you all have heard this as well in terms of hearing from our Black and Brown students and wanting to take certain courses or looking at who the professor is and assuming that racial identity is automatically equated with knowledge. And so I was just curious in terms of how you all, look at yourselves, how you approach your teaching. And so I would just want our audience to know how equipped and valued our guest speakers are, and how intentionally they work to connect with different people across the campus to ensure that they're providing the lens that really support the student experience.
Well, thank you for that. And I would also say, I think we want to hear from students, right? I can't imagine that I'm meeting all of my students' needs right now. And the more I can let students know that I want to hear what they are, the more likely I am to be able to meet them or to find somebody who can.
Mm-hmm. That's a great start.
I have a question. So I also want to enter the medical field whenever, after undergraduate. But what can I do to eliminate the racist implicit bias in myself once I enter the medical field, since some of the racism is like embedded in the education itself?
Yeah, so I'll go first, but I won't. So if you know me, one of the things that you quickly know about me is that my wife is a librarian that's a lot smarter than me. And, she likes to talk about books as, mirrors, but also windows, right? And so just one of the things that you can do, without even, during COVID times, without leaving your room, is read. Go through that syllabus that we'll link to, but not just academic stuff, not just history and science, novels, music, just embrace it, just put yourself in it as much as possible, and you still can never experience it, right? But yeah, I think that's one thing. Just surround yourself with those voices.
Yeah, we are definitely two people who are more likely to tell you to read than perhaps the average man on the street. I also would highly recommend reading. But I would also say, I think this question of racism in healthcare is part of a much larger conversation about racism in America and racism in the world. And I think there's We are living in a moment where the resources available to people who want to educate themselves in anti-racist ideas, strategies, ways of living are multiple. There's really great resources. And I think, one thing that I'm constantly finding myself checking myself on is I notice when things don't seem right, but when am I comfortable, right? When am I complacent? When do things feel right to me? And should it, right? If there's a classroom with mostly white students and a white faculty member, does that feel comfortable? Maybe it shouldn't, right? What is missing? And so, I think it's about being deliberate. I think, asking, and then making sure that you're supporting, if you're in medical school, making sure that you're supporting your classmates who might be struggling with different aspects of it. How can you be somebody who is not more part of the problem than you have to be? But yeah, there's a lot of really good books out there. I'll second the books.
And Trish, the fact that you're asking that question, I think already puts you leaps and bounds amongst some of your friends and peers who may not necessarily be thinking about their own biases, their own privileges, their own assumptions about the way they see the world. There's also trainings that are available online. And if you send me an email, I can connect you to some implicit bias trainings that might be something you might want to look into. But yes, read and be intentional in what you're doing in your time here. And I think you will see the difference in your own ability to care for people when you're in the field.
Yes, ma'am. Thank you. And thank you, Trinity, too, for the...
And you should be, at least, this kind of stuff is now part of training, as you're going through medical school and stuff, and what, similar programs. Kind of like in one of our previous answers, you're going to have a wide range of places that take it. There's a spectrum of seriousness to it, right? A 2-hour, lunch and learn event at your clinic is different than people who take it as part of a serious, course of study. But it's out there now. It is part of the training. You can be one of those people that take it seriously. I have, colleagues that run those trainings at psych clinics and nursing clinics and stuff like that. And you can be one of those people that take it seriously, or you can be one of those people that just wants to get that little certificate at the end so they can move on. So, but yeah, the fact that you're asking the question suggests what kind of person you'll probably end up being.
And we wanted to provide you guys with additional resources. So we had hoped to have it up on the pre-health website before this event, but website editing it's a magic I don't understand. So we have worked with the library, the UTC library, to compile a really lovely list of healthcare related readings, articles, novels, books, media, and it's not just focusing on African American narrative, it's actually focusing on all different types of minority groups. And so I will be sure to email all the participants that link prior, in the next day or so, but hopefully it'll be up on the website soon, and that will link you through to a lot of good content, and as students it's free. You can access it and start reading. So if you're not quite sure where to start once you get through that syllabus, this is another good resource as well. And I think we had a question in the chat. So Trinity also shared that A Medical Apartheid by Harriet A. Washington is a good read if you want to address the history of bias. So I will coordinate with the library to see if we have that and get that added to the list, so folks can check that out. Thanks so much.
Back to the reading. Some of these recommendations are fantastic. And plus we've got that syllabus up there. Form a nursing student or health and human performance book club, right? Do something like that. Meet once a month or whatever via Zoom, right? Or whatever.
Which looks great on an application.
Yeah.
One of the exciting things about the internet, but there's also a number of good I think especially if you're interested in the historical aspect of it, I know that historical scholarly writing can be a little bit dense, can be a little, you know, I find it fascinating, but it's its own special thing. But that more and more historians are writing for a popular audience, and a lot of us are really writing with medical practitioners and nurses and other health professionals in mind, right? We want our work to be accessible. So there are blogs like Nursing Clio is a great one, Somatosphere. I'm typing these in the chat as I talk. That you know, deal with these sort of questions about where medicine and medical science intersect with society and culture and people. And so those are other places if you want to sort of dip your toe in before you commit to a 300-page book. I highly recommend those.
PubMed also is a good, I'll put it in the chat too. It is 30 million strong of medical research spanning all different types of discipline, all different kinds of research. And it's a good resource to start learning about medicine, but also it's a good way to sort of see how your bias falls. Like, so as you start reading this medical research, you know, like it was mentioned earlier, does this feel off? Does this feel like maybe it's written for a specific audience when it should be written for all audiences? Or is it going to trigger something where you find, oh, this topic is really fascinating, and it leads you down this lovely trail of research? And that's something that medical schools are really encouraging folks in the time of COVID to do, is really dive into research, since shadowing and engaging with other medical practitioners face-to-face isn't really an option right now. Getting involved in research is fantastic. And so this is a way to not only help you grow as an individual, but also help you grow as an applicant. When you're getting ready to apply, you have a really good, solid application to submit. I'll put that in the chat as well. Any other questions? Insights, thoughts, things we want to share?
Join us for our next event on Monday, September 21st at 4:30.
Absolutely. So that's where, so like I said, this is a 6-part series. Our next is sort of unpacking what we've learned today, how we can take history and move forward and apply it to the present day. And so we will have lots of lovely speakers, maybe some familiar faces, but we really hope that you guys come and join us and enjoy the discussion and the application of what's coming down the pipeline.
Thank you guys for sticking around till after 6. I know that this is sort of the witching hour.
So thanks to our guest speakers, Dr. Comiskey and Dr. Johnson, for your time and expertise and just your ability to be vulnerable and share what you know with us. We really appreciate it.
Thank you for having us.
Yes, same. Thank you.
And with that, we will close. If anyone has any other questions they want to hold on, but I think we'll officially end our first event. Thank you everyone for coming.